Well, good evening to everyone. Let's see if I can get this to work. Yes, I think it is. There we go. Hey there, folks. How's it going? Happy New Year. It is 5 o'clock on the Gulf Coast, which means it is time for Fertility with Fink. 5 o'clock Gulf Coast means it's 4 o'clock in the mountains, 3 o'clock on the West Coast, and 6 on the East Coast. My name is Dr. Randy Fink, and here I am live tonight from Pensacola, Florida, where I guess I can't really be the first to say Happy New Year because we're a little late for that because we're the 6th of January now. So Happy New Year to everybody. We were off last week. I hope you had an absolutely wonderful and fantastic time over your holidays, and that it was just great to chill out and have a little vacation. I hope you got some vacation time. You got to see some family. Hope you got some gifts, maybe the lumps of coal, whatever suited you this year, whether you were on the naughty list or the nice list. But in any event, I am very happy to see you this evening because I missed you. I really, really did. And here we are to kind of talk about the things that are most important to all of us. And that's things about fertility. That's things about having babies, about making families, things about women's health, things about reproduction, and everything that you've got on your mind tonight. So please throw your questions my way, and let's say hi to all of our friends. Hey there to Red Bear. Thank you for being here this evening. Hello, Ruger. Yes, indeed, from Montgomery. I'm glad you are here with me tonight. Thank you. Rosa, how's it going? I hope you enjoyed your first holiday with the new baby. Marlena missed the program last week. That's because we weren't here last week. So thank you. Hey, Zenny in Miami, thank you for being here, and Happy New Year to you. Lots of celebration down in Miami in the Doral area tonight and in these last few days, I think. Hey, Grace, it's good to see you as well. Hi, Tracy in Miami. Looks like Marlena and Sheila, you were the first two to join on my Instagram, which is right here. We've got Plant Honeys over here. Good evening to you. This is New Life's Instagram. And of course, we have Facebook, LinkedIn, and YouTube right here as well. So New Life Fertility is located in Pensacola, Florida. We have an office also in Tallahassee and in Mobile, Alabama. I also do some work with the Missouri Center for Reproductive Medicine, and their office is in St. Louis and in Tulsa, Oklahoma, where we will be next week at this time, live from Tulsa, Oklahoma. So there's a little something to be excited about. Get a little change of scenery instead of the brick wall here with me. Hey, so what'd you do for your New Year's? What was that all about? I remember, kind of in my younger days, New Year's Eve was a very exciting time. It was something I really wanted to outdo myself every single year because, it just had to be one better than the year prior. And I really did some very interesting and fun things on New Year's Eves. But eventually it got to the point where, too many people out there drinking, too much, loud noises, late nights. And it got to be that, it's nice to just kind of eventually go to bed, do something fun, do something to celebrate because, yeah, it is a special night. But it's sort of like having an anniversary on Valentine's Day. What you come to realize is that when you go out on Valentine's Day, there's prefix menus. Every prices are all jacked up. Service typically goes down. Same thing, really kind of may hold true for New Year's. It's kind of another night where they can raise prices on things. But you know what? You get to wear a little hat. You get to have a noisemaker, and you get to stay up till midnight. So I guess that's that's kind of the best you can hope for once you reach a certain age. Hey to Lexi and to Desi Banks, howdy, and hello to the Bama gal in Mobile. That is my sweet mother and father in Mobile, Alabama this evening. So let's see, we had I had a couple of questions that floated my way through the internet. And if you are unable to get a question in here with me during the live broadcast, feel free to email me, and that's at askfertilitywithfink at firstfertility.com. That's askfertilitywithfink at firstfertility.com. fertility.com. New Life Fertility is as is the Missouri Center, part of the First Fertility Network. We're very proud to be part of such a fine organization. But question-wise, the first question is something that I think I've actually had this question before. Does my husband have to do a semen analysis in order to get treated? What are the odds that something is wrong? And the answer to that is, well, I mean, in any individual scenario, it's hard to say what the odds are that something's wrong with sperm. But we know that in 40 to 50% of cases, issues regarding infertility are actually related to male factor. It absolutely, positively is a real thing. So yes, part of the evaluation that we do of the couple is just that, and that's to evaluate the couple so that we know that exactly what we're dealing with, both from a female side of things and from a male side. So occasionally I will hear that a male partner will say, nah, you know what, I don't want to participate. And we say, well, this is a couple's thing. This is important, and doing a semen analysis is pretty much as easy as ejaculating into a cup. Now, most guys don't really like the idea of doing that, but providing a semen analysis is really easy all day long. At our front desk, people are bringing in brown paper bags, so it's not an embarrassing thing to do. We have you collect that semen analysis at home so that it is just much better for you rather than having to come and do it here live. So semen analysis is a very important part, and we really want to take care of the couple, not just one side of things. Let's see. Hi, Mrs. V. Good to see you. And Alicia Joy, nice to see you tonight here as well. Kaylee Burdick says, can I transfer my embryos to New Life if I want you to do my next transfer too? Oh, thank you. Yes, absolutely. We can definitely do that. We do take care of people from all over the globe here. If you were with me in my last practice, our practice here at New Life is certainly a different type of practice. We're a little bit more nuanced and boutique-y. The physician, that is me, or my partner, Dr. Rips, is involved in every decision that is made on your behalf. Every decision is made for you is made by your doctor. So yes, absolutely, Kaylee, and I would be very, very honored. Thank you for asking. Rosa says, my transfer was modified natural this time in about a year. Can I still do modified natural, do you think, or is completely medicated better in older women? I'm 43 now. So the evidence for a medicated transfer versus a modified natural really does not depend on age, as long as you are not menopausal. So basically what that means is that, well, if you're all out of eggs, if you're not making eggs anymore, then trying to get you to release an egg in order to have you making your own estrogen and progesterone is going to be an uphill battle. It's just not going to work. And in that scenario, a medicated cycle really is the better thing to do. But if you're having periods, Rosa, 43, I would say a modified natural is absolutely fine. There's no harm to that. So the difference there, and in fact, the evidence shows us that there are some studies that show that doing the modified natural actually may have a little bit higher of a success rate relative to medicated cycles. These medicated cycles have been the type of cycles that have been done in the IVF world ever since IVF was invented. So most practices really do a lot of these, they're predominantly medicated cycles just because it's easier to control all of the variables. But in a modified, so basically there, we're giving you all the estrogen, we're giving you all the progesterone, and really coordinating everything that's going to happen for you hormonally. Whereas in a natural or a modified natural cycle, we're causing your body to make your own estrogen or progesterone. In the modified natural, because we're doing some ovulation induction, or in a fully natural cycle, you're just making it all by yourself. I think that's actually a pretty good idea. There is a little bit more variability. Sometimes there can be some things that change things, that make it a little bit less predictable, but nothing that we can't handle. So yeah, Rosa, absolutely, that's what I would do. And let's see. Plant Honey said, should an egg retrieval be done before a laparoscopy, or can they be done afterwards? So my recommendation would be that you do your egg retrieval first. And why do I say that? Because every day that goes by, we start to lose eggs, right? And even if you are of the age where, well, not really expecting you to be losing so many eggs, egg quality suffers as each day goes by. So sometimes what happens is that folks decide they're going to do a laparoscopy, and they go to have the surgery, and then it's months later before they decide they're ready to do their egg retrieval. And so you've just really lost that time in terms of both egg quantity and quality. My recommendation is that as early as possible, you do your egg retrieval. You make your embryos. You maximize what you're going to make in the embryo department because of two things. One is, if you have a laparoscopy and you start doing some things in the ovaries, that will, by necessity, decrease your AMH level. That will lower your ovarian reserve. So we really want you leaving your ovaries out of the equation if you're going to have surgery. So much better to go ahead and get your eggs, make your embryos, because those embryos will stay frozen and stay good forever. And then you can have surgery, do what you need to do as far as the laparoscopy goes. And then once you're recovered, come back and let's do an embryo transfer and get you pregnant. So hopefully that makes sense, but 100% that's what I would do. Really day in and day out. Hi, Mama Fran. And Madison Faith says, my husband and I had our first baby via IVF with you guys in September. We want to have baby number 2. Would we need to start back at square one with tests or jump back to IVF? So the first question is, well, if you have other embryos frozen, then really what we do is we just update some laboratories. We want to kind of look and see, well, where's your estrogen level, and make sure your prolactin is normal and your thyroid hormone, your thyroid's functioning normal. And then you just go into an embryo transfer cycle, and it's really very, very easy. If you don't have embryos that are remaining, we kind of look at some similar things, want to see where your ovarian reserve now is, your AMH, but then we'd have another visit and kind of look at, well, do we need to change anything? How did you do with your first stimulation? Do we want to tweak things based on where we are if we have to do IVF again? Hopefully the goal is that when you do IVF, you have enough embryos that those embryos can stay frozen and you don't have to go through that whole process again. So I think, Madison, it just kind of depends a little bit on where you are in that process and what you have frozen at this point. Hello, Stephanie. Nice to see you here on the New Life Fertility side. And Madison answers a question. We don't have any more embryos. It was mainly a male factor issue. So in that case, well, you start over, but you're not really starting over. You don't have to do all that initial testing all over again. It's just really kind of updating where you are in terms of hormone levels and what we can expect from a response with the medication for you. Let's see here. What do we got? I saw some other questions over here, and that was, Desi asks, what about an HCG wash and intralipids? What are they, and are they actually helpful? So both the HCG wash and the intralipid infusion are add-ons that are considered part of an immune protocol. So we know that the immune system has some impact in our ability to get pregnant or sometimes to stay pregnant. There are some practices, such as mine now, that will test for certain things when it's indicated to look to see who is appropriate for any particular type of intervention or any type of add-on for the immune system. There are some practices who have a slate or a menu, as it were, of immune type add-ons that they give to everyone, thinking that, well, these are going to help some people. Rather than going through extra testing, we're going to give it to everyone, knowing that some of the people are going to be helped by it, and it's probably not really going to hurt anybody. I don't necessarily buy into that, because while I do think that many of these interventions are very straightforward and are not harmful, I think it's more useful to tailor an approach to fertility rather than to use a one size fits most and kind of give it to everybody. So two of those things, the HCG wash and the intralipids, are designed to address different things specifically. So intralipid is an infusion of fat, literally a fat infusion. It is something that is typically used in folks who are going to be having what's called total parenteral nutrition. So let's say that you have someone who is comatose, who's in a coma in the ICU and can't eat on their own. They can get basically a big bag of liquid nutrition to provide them the nutrients they need. And one of those types of nutrients is some fat in the diet. From an IVF standpoint, using intralipid is really like having an infusion of the keto diet. Keto is anti-inflammatory, or is said to be anti-inflammatory, and that fatty infusion may have some benefit on diminishing inflammation. Specifically, intralipid is to turn down the effect of what's known as natural killer cells. Now, the whole thing with natural killer cells is kind of difficult, because it's not something that we can just simply, and that's a type of immune cell that can stand in the way of an implantation. Problem is that, okay, so we can test to see your level of what we call NK cells. We can test that. But what happens with that number? Well, it could be that your NK cell number is just fine, but the activity of the NK cells, that is what those cells are supposed to be doing, is that they're just actually not functioning, or maybe they're functioning too much. Maybe you have too many cells, maybe you have too few. So it's really, it's not something that we would routinely test in everyone, and the effect of those NK cells is really is controversial. But intralipid specifically is a treatment to combat the inflammatory response that is associated with boosting those natural killer cells. So that's technically what the intralipid is for. HCG wash is where we take the pregnancy hormone, human chorionic gonadotropin, or HCG, and we literally put it in a syringe and place a tiny little straw inside the uterine cavity and just bathe the lining of the uterus with the pregnancy hormone. What does that do? Well, it, in theory, increases the receptors in that uterine lining to the pregnancy, and it may improve the ability to implant. This is certainly true in folks who have had recurrent pregnancy losses. There's another thing that we can do for the uterine lining, and that is an intrauterine PRP wash, platelet-rich plasma. That's where we take a tube of your blood from your arm and prepare in the laboratory that blood to basically separate out your body's healing components, your tissue components, your tissue factors, growth factors, and literally can place some of that material back inside of you in different spots, in this case, inside the uterine lining. That's something that works really well also with people who have a hard time growing their uterine lining, getting that lining to become thick enough. That's really what an HCG wash is. It's designed to turn up the volume knob on the receptors inside the uterine cavity, and that's the endometrium. Let's see. Hi to Sarah and Tiff Tay. Matthew, good evening. In the Pinot Journey, I love the name. Shadia, hi, how are you? It's nice to see you. And see, I actually pronounced your name correctly. See, no mistakes there. Hi, Eileen. It's good to see you, Mrs. B. And I hope you are feeling well and going to be enjoying this new year. You've got some exciting things coming up for you, don't you? Let's see. Kaylee says, how necessary is Nivastim? What does it do? I remember it was prescribed last time and it was crazy expensive. Okay, so Nivastim is a particular brand of what's known as a GCF stimulator. I am at this moment blanking on the other name for it. There's another brand name that where I used to work, we would use it very commonly in people. And basically what that does is that it revs up your white blood cell count. So it increases your white blood cell. Your normal white blood cell count is usually less than about 10,000. So if I checked a blood count on you, your WBCs, your white blood cells, typically 7, 8, 9,000. Some people are lower, 3, 4, 5,000, but those are the kinds of numbers you see. When you're using a medication like Nivastim, it is boosting that white blood cell count. So it may be 30 or 40,000. That number gets really high. So that medication in particular is used in chemotherapy, for instance, for people who have had chemotherapy that's kind of wiping out their own white blood cell supply. Maybe it's affected the bone marrow, so you're not making as many white blood cells. That's really what that's intended for. But the thinking is, as it pertains to embryo transfer, that you may be decreasing or you may be, boosting certain parts of the immune system that may be helpful for pregnancy. Personally, that is not something I was ever particularly fond of using because I did not see that it is very expensive and it did not make a big difference in most people. Now, that same medication can be used in a wash inside the uterine cavity in order to help grow the thickness of the lining if there's an issue with that. So that's one place that I have seen it useful. And you caught me off guard here. I haven't thought about that medicine in a while. I just can't think of the name of the other medicine. But some insurances use Nivastim as the drug of choice, and others use the different one. Nivastim is actually sometimes a little cheaper than the other one as far as brand names go, but that's kind of what it's for. So my answer to you is, in general, I don't use it unless there would be a very, very special and very specific scenario. And I'm happy to talk more about that sort of thing with anyone if they are interested. The answer is yes, we do consultations from all over the country. I am happy to consult with you and look at your cycle, even if it's being done someplace else, and potentially give you some helpful hints or words of advice. New Life Fertility's email address, or rather website, is fertilityleaders.com, fertilityleaders.com. And that's an easy way. You can call us on the phone or you can ask for an appointment online. Hey, Midgie, nice to see you and Happy New Year to you. Hey, Equestrian, howdy, and hi, Noodles. Good to see you also. Guess what, folks? In 5 fun-filled minutes, 5 minutes, we are going to do the 5:30 Fuzzies with Fink, which is where we are going to send out all kinds of positive vibes to everybody who needs it tonight. We'll talk about that more in just a few minutes. Kaylee, I want to talk a little bit more about that without, trying to get too specific, that, you'd like to reduce the medications used. And that's a common feeling, because when you are doing embryo transfers, particularly if you're doing a medicated cycle, there are a lot of meds involved. There's a lot of estrogen. The progesterone injection gets to be difficult and no fun, frankly. And then you add all the different immune meds and everything to it, and it can really turn into a lot of stuff. When truthfully, the body really does make the estrogen and the progesterone on their own. Now, sometimes I think it makes sense. Good, easy thing to do, that low dose naltrexone, maybe even sometimes some prednisone, depending on the scenario. Those are simple things to do. They don't add a lot of cost. They don't add a lot of medication to it, but maybe do something like that with a modified natural FET, because then you're using a little letrozole to make sure that you're going to release an egg. You can trigger that ovulation to make sure that it's released in a timely fashion. Then you use a little vaginal progesterone just as a little local support, at the level of the endometrium. That's using your own hormones, putting them in the front seat, and it's far less medication. That's called a modified natural. Now, a natural cycle FET is where you don't do the ovulation induction, and then you're just kind of really waiting to see when you ovulate on your own. Now, obviously, that can throw a little bit of a curveball into things, because there is kind of a bit more variability involved with that. But so that might be some thoughts for you there, Kaylee. A question says, does the 95% chance of live birth still apply if I have had 2 euploid embryos fail and my third is transferred to a gestational carrier? Okay, so what you are talking about is okay, so when you transfer 1 euploid embryo, you have a 65% probability of pregnancy with that embryo. By the time you transfer a second euploid embryo, you're about at an 83% positive a chance for a positive pregnancy test. If you have to get to the third embryo, the odds of achieving a pregnancy are 95% with that euploid embryo. So it sounds like you've decided to use a gestational carrier. In other words, to take that embryo and to place it into someone else's womb who will be carrying that pregnancy for you. And the answer is yes, because you still have, this is your third euploid embryo. And so, yep, the statistics should really still hold there. So I'm guessing that you determined at some point that there was something else going on that was going to make it difficult for you to be able to carry the pregnancy. And hopefully you are alleviating that by going into someone else who will then carry the pregnancy for you. Gosh, my fingers are crossed there, Miss Equestrian. That is very exciting news. And I do want to say also here, thank you, Kaylee, for saying that the miracle twins that you transferred are almost, that I transferred are almost 2 years old. Golly, that is really, really fantastic stuff. All right, so what is this 5:30 Fuzzies with Fink? What is that all about? Well, I'll tell you. The world is not a kind enough place. I personally feel that we should be doing everything we can to try to extend kindness at every possible avenue, not just as it pertains to fertility, but as it pertains, to the people that we interact with, the people we work with, our family members, the people that we see in a store, a clerk at a store, somebody operating the cash register, the guy who's stocking the shelves. all those things. Somebody you pass in the hallway, a stranger, random acts of kindness are just a good thing, But as it pertains to fertility, um, this is, as I describe it, it is probably the crappiest roller coaster in the entire park. It swings you left and right. You hurt your neck. You get a concussion. You get whiplash. You get nauseated because it's turning you upside down. And the fire breathing dragon is breathing hot air in your face. And you really wish that you had never gone on this ride. Fortunately for most people, when that crappy roller coaster pulls into the station, you are able to get off that train with a lovely parting gift, and that's a baby. And somehow all that pain, all that misery, and all that discomfort that you had to go through to get there finally actually becomes worth it. If you watched my post on New Year's Eve, I said, my hope and my prayer for each of you is that this is your year and that all of that pain becomes something that you look back on and say, gosh, you know what? It was tough, but I got through it. I did it. And look at us now. We are so much happier for it. If you are going through this fertility business, I want you to know that you are not in this alone, that you are in this with every single other person who is on this broadcast and tens of thousands, probably even hundreds of thousands. And gosh, if we just kind of look at worldwide, millions of people worldwide, lots of people who don't even seek to do the things that you've done by trying to get care for this issue. You are not alone. We are all in this together. And now that we can take a moment to be here together, and if we could put our arms across each other's shoulders and say everybody's name, because I know that every single one of you on this broadcast would do pretty much anything to help anybody else on this broadcast, because that's the kind of people who watch this program. I want to say, here we are as one community, standing together, sending out the positive vibes, the good luck, the good feelings to each and every one of you from each and every one of you. And that, my friends, is the 530 Fuzzies with Fink. Good news for all of you ahead this year. There is plenty more adventure to come as your family grows. So fingers crossed. Thank you for participating in that. Do it 1/2 every Tuesday evening right here. We've got a couple of different Instagram. Mine is Randy Fink MD. Here's New Life Fertility. We've got Facebook, LinkedIn, and YouTube over here. Please ask your friends to join, even if it's only at 29 minutes past the hour next week until 31 minutes past the hour next week, because the more people that we can have here sending out those good vibes, the more I think we can break the internet and we can make sure that those positive vibes are felt by each and every one of you. Michael Lynn says, yes, the miracle does come. Thank you for sharing that. And I surely do believe it. Hey, Andre, nice to see you there as well. Question, how long do you recommend to prime for egg retrieval with a low AMH and diminished ovarian reserve? Well, so I used to think that, gosh, we can prime for a really long time. We can prime for, 90 days sometimes, just get a whole bunch of extra estrogen on board with that. The best evidence really shows that, all you need is about 21 days of priming. Or even just, if not a full 21 days, which is kind of what I like to do with my Omnitrope. But if you're talking about estrogen priming, really just some priming in the luteal phase of the cycle before you start stim. So that's like if you have regular periods starting on about day 14 of the cycle before, there's very good evidence that that's all the hormonal priming that you need, and that's particularly for women with a diminished ovarian reserve and that is a lower AMH. Sometimes, like I said, we do that for longer, for 21 days. Again, that's what I like to use with Omnitrope. Um, and I want to mention one other thing since we're on the subject here of priming. Omnitrope is somewhat controversial because there are some studies that show it makes a big difference, and there are other studies that show all it really adds is cost. It's expensive. Omnitrope is human growth hormone. And that human growth hormone, in my mind, may have the ability to help stabilize some of the aged, damaged DNA that's in the ovaries and thus create better egg quality. So that's sort of how I use it. Empirically, I think it does make a difference. There's another medication that is out there that you may have seen something about, and that is something that is called rapamycin. And it got some press in the not too distant past, rapamycin, which sounds like it's some form of an antibiotic like erythromycin, but it's not. It's actually, technically speaking, it's an immune-related medication. And what it is predicated on is this idea that some egg quality, some loss in egg quality happens as a result of basically certain proteins in the cells, ribosomes is what they're called, starting to diminish, starting to unravel is kind of a good way to think about it. And so they did some studies using rapamycin in looking at mouse eggs and looking at egg donors to kind of see if it improved things, and they found that it did. And so the press grabbed a hold of this and said, "Oh, this may be the newest thing for diminished ovarian reserve and for women who are getting older, who have egg quality problems, who are doing IVF." They actually did some additional studies looking at rapamycin and its outcomes on people with diminished ovarian reserve and things like the live birth rate. And they did find that this rapamycin in a dose of 1 milligram per day improved outcomes. So the question is, should we be using it? Should we be offering it to people? And the answer is, well, I am certainly thinking about offering that to folks because it is it's an adjunct, it's an add-on. We don't really know the effect. It's experimental, and that's the thing. Is it going to hurt somebody? Well, I think the data is too early for that, but it certainly seems to be helping some people. You take it for about 21 days. It's not something that you're on for the long term. The problem is that it does have some side effects, and the things that I read about, honestly, I haven't had anybody on it yet, so I can't say personally, but things like, the things I saw, it can cause some painful mouth sores. And I'm like, ugh, ooh, that doesn't sound like something I would like to sign up for. But my guess is that it probably doesn't so much happen in people who are using it for short term. There are some people who are on this medication for long term due to autoimmune type problems or things that require prolonged immune treatment. And it may be certainly much more likely to happen in that group of people. So rapamycin, rapamycin, is something to look up because, it may be the next thing out there. It may be, better than Omnitrope, because Omnitrope, again, the data on it is pretty conflicting and it's very expensive. Whereas, I think I looked on Good RX to see what the price was for the rapamycin drug, and it's like $30. It's, and that's for a month supply. You don't even need a month supply. You need 21 days. So, there may be something to that. Do your own research, take a look, and see what you think. Kelly Lee, good evening to you. We did an embryo transfer in December of 2021, and our son is 3. What a great age. Planning to come back soon for our second. We can't wait to see you here. Gosh, I think actually 4 was probably my favorite age, because then they're talking like little people. They sound so cute, but they're still kind of innocent, but they sound a little more, like bigger people. 3 was much worse than 2. Everybody always talked about the terrible 2s. For me, it was the terrible 3s. 3 was definitely tougher because they have so much more of an identity that they are trying to assert. But I hope you are having a great time there, Kelly, and that you are loving every minute of it. And we can't wait to see you back. That reminds me of one other thing before I hop back into these questions here. And by the way, it's about 20 minutes till the top of the hour. We'll be here for about another 20 minutes. And then every Tuesday, Fertility with Fink right here. When I look back on when my kids were little, everybody would always say, oh, little kids, little problems. The bigger your kids get, the bigger the problems get. And that's probably true. But, when you have the little ones, there are so many challenges, getting them potty trained, getting them to eat, dealing with their finicky diets, getting them, keeping them from harming themselves in the house, worrying about them in school, and worrying about their moods, and trying to teach them the right the right ideals in their life, the way they practice their life, making sure that they go to sleep, for crying out loud, go to sleep, and please don't wake up at 5 o'clock in the morning. It's all of those little things when you have little kids, and it's exhausting. It really is. But I got to tell you, looking back on it, I sure wish I could do it again. Because every single one of those days I treasured, and I wish that I knew now what I knew then, or I wish that I knew then what I knew now. How quickly that time goes by, how quickly go the days, because they really do. And so to treasure each moment there. And the same thing holds true with kids of any age. For sure, you can always treasure that time with them. But I was thinking around the holidays here, because I've got an 18-year-old, a 17-year-old, and a 13-year-old. And I'm like, gosh, it sure was easier when I could go and buy them toys and find things for them that I thought that they would like. Toys were the best. I could go and get little Matchbox cars because it was perfect in their little hands, and they loved them. And if only things were like that. And Kelly says, yeah, the best kind of exhausting. It keeps you on your toes, I'm sure. We're already in our why phase. Why? Because I said so, that's why, right? You know what I'm talking about there. Noodles says, hi, Dr. Fink. I'm doing suppression for silent endometriosis due to the BCL6 marker. I had an early miscarriage with a euploid embryo transfer before. So could the silent endometriosis be the reason for miscarriage, even though the embryo implanted? The answer to that is yes, it absolutely can be the reason. And that's because of what we think that endometriosis and that BCL6 marker does to you. So let's take a step back for anybody who doesn't know what we're talking about here yet. Endometriosis, is that process where that lining of the uterus that normally comes out when you have a period instead works its way up north into your pelvis. It can implant, it can cause a pain syndrome. In many cases, it doesn't have any symptoms at all. It can cause some scarring. It can cause a decrease in your ovarian reserve. But what we have learned is that it also can cause recurrent implantation failure and potentially be associated with recurrent pregnancy loss as well. So the only way we used to be able to diagnose endometriosis was by doing a surgery. It was by putting a camera, a laparoscope, in through your belly button to take a look around. I am not a believer in the laparoscopy for fertility for most people. We can talk ad nauseum about that, but I feel pretty strongly. There are some cases where it's necessary or indicated, but in the olden days, everybody would have a laparoscopy. Nowadays, that's really not something that's needed. The evidence is very clear on that. But so now we can diagnose silent endometriosis through a non-invasive test, and that's called Receptiva. Receptivadx.com is the website for that, and that's looking for a particular marker that's called BCL6 in the uterine lining. It has to be tested at a particular time of the cycle in order to be considered accurate. But if that BCL6 marker is there, it is associated with pregnancy loss and implantation failure. And the reason for that is that we think that BCL6 is an anti-progesterone. So progesterone, right, is the hormone that your body uses in order to maintain the pregnancy. An anti-progesterone fights against, or it blocks that progesterone from being able to do its job. So yes, you got an implantation, which means, okay, that's a step in the right direction. We know that at least everything was working right, the plumbing all connected so that that embryo was able to implant, but for some reason it stopped growing. Well, we usually say in most cases that is an embryo issue, but in the face of BCL6, yep, absolutely, that can be an anti-progesterone at the level of the endometrium, which can cause a pregnancy to fail. So yeah, it can. The right thing to do for that is you treat it for 60 days with some suppression, and it sounds like that's what you're doing there, Noodles for Life. Oralisa, Myfembry, those are the two oral medications, or you can do that with Lupron as an injection as well. So sounds like you're definitely doing the right thing. Hi to Shine, looks like Shine 10. Libby, howdy. Hi, Sweaters for IVF. It's good to see you here too. An embryologist 65. Howdy. Thank you for being here in that mask. Appreciated. Katie B. Doing Things. Nice to see you over here on the Instagram side. On the New Life side, I guess I should say. So let's see what else we have to talk about here. I actually want to mention a little bit more about the endometriosis, because treating and how do we know that this BCL6 affects the implantation? Well, so you said there, Noodles, that you had a euploid embryo. That euploid embryo gives you about a 65% probability of pregnancy. So that's all real good. In the face of a positive BCL6, that 65% number can drop down to less than 10%. That's pretty significant, right? That's a pretty big deal. Unless we know it's there and we treat it. And if we treat it by suppressing the endometriosis hormonally, and that is basically turning down the estrogen level for 60 days, then that takes your less than 10% number and brings it right back up to the 65% number. So I think I talked about this a couple weeks ago. Some people say, well, can I treat it for 1 month instead of 2? Or my doctor told me I needed to treat it for 3 months. The evidence is 2 months. Does 1 month work? Maybe. Does 3 months work any better than 2? I don't think so. The evidence is 2 months is enough to suppress BCL6 or endometriosis in the uterine lining. So that's what I tell people. For 25, 30 years, the only medication we ever had for that was Lupron. Lupron is a shot that you get that quite literally pulls the plug on all of your hormones so that your hormones are just shut down. It puts you into a temporary menopause. And that doesn't feel great because you get the menopausal related side effects. You get some hot flashes, you get some vaginal dryness, you get some mood change, you get some, you may get some leg cramps, you may not sleep as well. there's a lot of stuff that goes on with that. The oral medications are better tolerated than the Lupron. So that tends to be what I grab for now. Now, in some cases, if someone has failed Lupron, let's say that we did or failed Lupron, you failed Orilissa. Let's say we did some Orilissa suppression and then did another euploid embryo and you still didn't get pregnant. Well, if we have to suppress again, then 100% I'm going to say, let's use Lupron because I want to shut everything off at that point. And I really want to control it all because once, we've used 2 euploid embryos, it's really time to start, got to turn over every stone, look for everything and do everything that we can because those are our top quality embryos. Those are the ones that should be getting us pregnant most of the time. Hi to David and to Mama C. Nice to see you guys here this evening. Let's see what else we got going on here. There was another question here about sperm that came in by email, and that was, does abnormal morphology cause infertility? Okay, so what is morphology of sperm? So when we do a semen analysis, we're looking at a bunch of different things. We look at a sperm count. We are looking at, if you just heard an airplane go right overhead, it's, we're real close to the airport here, so it often sounds like the airplane is landing on the roof. So if you just heard that wherever you were, you weren't crazy. It was real. We look at the sperm count. We look at the percentage of the sperm that are swimming. We look at the volume of the semen to see how much is there. And somebody's job is to sit in a microscope and look under that microscope at sperm and to tell us, what do these sperm look like? Sperm have a head, they have a neck, and they have a tail. And so somebody's job is to comment on those heads and those necks and those tails. What's normal for us as humans is that 96% of our sperm are abnormal, which is crazy, if you think about it, that 4% normal is all you should expect to see normal from a normal semen analysis. Now, some people have 8%, some people have 10%, but 4% normal forms is all that really has to be there for that semen analysis to be normal. So when we have greater than, or I should say less than 4% that are normal, that's what's called teratospermia. Teratospermia. So when we find a single semen analysis that may be abnormal, we usually say, well, depends on how abnormal it is. Most of the time we'll say, let's repeat it, because a single isolated finding doesn't necessarily mean that there's something that's wrong, because everybody's entitled to a bad day. Maybe you missed some in the collection. Maybe, maybe you weren't feeling well, or your body was fighting something. And so a single semen analysis is not considered diagnostic. But let's say you have a couple of semen analyses that have abnormal morphology. Well, that morphology, or the heads and the necks and the tails, is not considered to be a cause of infertility. However, there is an association between the teratospermia and couples that are having a hard time getting pregnant. So the thing that makes me wonder about is, well, gosh, if the sperm don't look normal, is there something persistently wrong in the DNA of that sperm? So what's a sperm? It's a little package of DNA with a motor on it, right? We can see the motor, we can see the little tail moving along, and we can see where the package of DNA exists, which is, in the sperm itself, but we can't see the DNA. There is something that's called DNA fragmentation, and we can test for DNA fragmentation through what's called an SDFA, or a sperm DNA fragmentation index. That persistent teratospermia is one of the indications for an SDFA, because if it turns out that more sperm are are have their DNA fragmented, and that means that the genetic material in the sperm itself is kind of starting to come apart, then we will find that things like timed intercourse and things like IUI are not going to be as successful, that they are just less likely to work. And in fact, in most cases where I have seen a DNA fragmentation test be abnormal, and in that scenario, we will always recommend IVF. For the folks who said, nope, I don't want to do IVF, I'm only going to do IUI, I've never seen one actually get pregnant. So there really is something to do that. Now, it's not that you can't get pregnant, because certainly you can. It only takes one sperm to get the job there. But we're talking about trying to be reliable, trying to get you pregnant sooner rather than later, and in the most efficient manner possible, and so that's what morphology shows. It's not something that again is a cause of infertility, but rather is associated with folks who are having a harder time. It's associated with subfertility, but that's really the reason why. So we do that SDFA test to see about the DNA that's actually in that sperm. And I believe that looks like Mason, who has joined us tonight. Hello, Mason. Thank you for being here, sir. Well, so what else is going on here, folks? We're going to be wrapping it up in just a few minutes. So if you have any last minute questions to throw in, please feel free. Or if you don't want to ask them here, you can email me, and that's askfertilitywithfink@firstfertility.com. Next week, I will be live from Tulsa, Oklahoma at the Missouri Center for Reproductive Medicine, where I'll be doing some embryo transfers. So we'll be able to maybe talk with an accent. Maybe I'll get to wear a big hat or something. Is that allowed? Am I allowed to wear? Am I allowed to wear a cowboy hat? I will have to ask management if that's okay, because I'm just going to say I look mighty fine in a cowboy hat. I just want you to know. Every Tuesday evening at this time, we come here for Fertility with Fink. And halfway through this broadcast, every time we do the 5:30 Fuzzies with Fink, where we stand together as a community and send out all those good vibes to everyone who is in need. So to each of you tonight, whether it is fertility that's getting you down, whether it's school, whether it's relationships, whether it's work, or whether it's just life out there, maybe it's just nice to know that somebody is here with you, that somebody is willing to give you that virtual hug. That's what we're here for. And I think everybody on the broadcast tonight is glad to be of service. So this fertility business is not the book of your life. It is just a chapter. And what are we here to do? We are here to rewrite that thing together. So every step forward with kindness, as we said, there is not enough kindness in the world. Every step forward with love. And most importantly, every step forward with hope. Because tomorrow is a new day, and it's full of all new adventures. So until next week, from Pensacola, I'm Dr. Randy Fink. Thanks so much for being here, and good night. See ya.